Good morning, everyone. Good morning. Welcome. Thank you for joining here for the homeless for our first policy seminar on the trauma of homelessness. My name is Delise DuPont-Glenman. I am the chair of the board of directors at Care for the Homeless. We are an organization that fights homelessness by delivering high-quality and client-centered health care, human services, and shelter to homeless individuals and families, and we advocate for policies to prevent and end homelessness. With almost 35 years of experience providing care to people experiencing homelessness, Care for the Homeless has become a proven leader in the field. We currently operate 24 federally qualified and New York State licensed health centers throughout the Bronx, Brooklyn, Manhattan, and Queens. We also operate 2 women's shelters, one in the Bronx called Susan's Place, and one in Manhattan. Care for the Homeless direct care staff includes intensive care case managers, clinical social workers, substance case counselors, and housing specialists. The medical teams include primary care physicians, psychiatrists, nurse practitioners, dentists, podiatrists, social workers, and health educators. Most of our service sites are co-located at facilities operated by other nonprofits that include shelters for single adults and families, assessment centers, soup kitchens, and drop-in centers. Additionally, our community-based health center model brings services directly to neighborhoods where the need is most significant. Both models reduce barriers homeless New Yorkers regularly face in navigating a complex healthcare system by increasing access to high-quality care. Homelessness carries an ugly stigma. It's often viewed as a characteristic, something that cannot be changed, but it truly is a condition. Conditions are treatable. Our accessible co-location and community-based healthcare models provide these essential treatments, working as a catalyst to break the cycle and to alter the perceptions of homelessness. As I mentioned, policy is an essential part of what we do at Care for the Homeless. We believe that bad policies created homelessness, and therefore better policies could end it. We conduct several public education events throughout the year, and this seminar is an integral part of that effort. Convening elected officials, advocates, services providers, academics, and people with the lived experience of homelessness gives us a platform to discuss opportunities to not only respond to the immediate crisis of homelessness, but to contribute to long-term solutions. The goal is to develop policies and procedures that will guide the delivery of well-rounded services, which is the only way to end homelessness. Today we're joined by an excellent group of panelists who will be joining us on stage shortly. But first we have a few special guests who will be sharing some remarks with us. Our first guest joins us from the U.S. Department of Health and Human Services Administration for Children and Families, an important ally in providing critical services promoting the economic and social well-being of families, children, and individuals in New York City. Notably, ACF funds Head Start and Early Head Start programs that serve children, pregnant women, and toddlers, as well as programs supporting runaways and homeless youth. All essential programs in the fight against homelessness. Please join me in welcoming Lead Program Liaison, Ms. Barbara Andrews.
Good morning, everybody.
Good morning.
Thank you, Delise, and thank you, Natalie, wherever you are. Okay. Or is it Natalia? Okay, thanks. Well, happy Federal Fiscal New Year. Today is the first day of fiscal year 2020. And My name is Barbara Andrews, and I want to welcome you to 26 Federal Plaza, one of your federal buildings in New York City. Congratulations on getting through security. I hope it wasn't too painful or arduous. As you heard, I'm with the Administration for Children and Families, that's ACF for short, and ACF is one of the human services agencies within the U.S. Department of Health and Human Services, HHS for short. This morning I'm bringing greetings on behalf of Joyce Thomas. Joyce is the Regional Administrator for ACF in Region 2. Region 2 includes New York, New Jersey, the Virgin Islands, Puerto Rico, and 8 federally recognized Native American tribes. It's good to see some familiar faces, colleagues from the New York City Continuum of Care, the New York City COC Youth Committee, the Mayor's Task Force on Youth Homelessness, New York City Youth Camp, the U.S. Interagency Council on Homelessness, USAGE for short. The federal government, if you don't know, loves acronyms. HUD, the U.S. Department for Housing and Urban Development, and from my own agency, ACF. I know that some of my ACF colleagues are expected to be here. If you have arrived, I can't see very well, so if you've arrived, please stand. If not, okay, catch you later. Okay. And since we are in New York City, I should explain that because of the similarity of our names, many people confuse the Federal Administration for Children and Families with the New York City Administration for Children's Services, ACF, ACS. It gets confusing. The theme for today's meeting, trauma and homelessness, is extremely important and very relevant because there's no doubt being homeless is a traumatic experience. Even a short period of homelessness can have a long-lasting impact. Home is a basic human need. Home represents safety, no matter what your age, child, youth, adult. It's stressful not to have that physical place, and it's also stressful not to have that refuge, that sanctuary that home represents. What's more, physical health, mental health, and housing security are intertwined. In addition to the stress of experiencing homelessness, persons experiencing homelessness may be affected by a variety of health challenges because of difficulty accessing regular health care or not having a medical home. That's where organizations like Care for the Homeless and HRSA, that's the Federal Health Resources Services Administration, who you'll hear from, I believe, later on, that's where these organizations come in. Often, homelessness is accompanied by interruptions in education and disruptions in family dynamics. Children experiencing homelessness are sick at twice the rate of children who have stable housing. And I probably do not need to tell this group, but I will tell you anyway, that adverse experiences during childhood can have a very long-term effect. The Administration for Children and Families is dedicated and focused on improving the economic and social well-being for children, families, and communities. That's because children grow best in a safe and nurturing family, and families do best when the community around them is safe and stable. ACF administers more than 60 programs as well as special initiatives. As you go around your neighborhood, you will not see a sign that says ACF. But I'm sure you're familiar with many of our programs because many ACF programs have a very direct relationship to persons experiencing homelessness. Programs like Temporary Assistance for Needy Families, TANF, the Runaway and Homeless Youth programs like Street Outreach, the Basic Center and the Transitional Center programs, the maternal child group homes, child welfare, the Child Care and Development Fund, and you already heard from Delise, the Head Start and Early Head Start programs. ACF also funds the National Runaway Safe Line, 1-800-RUNAWAY, and the National Clearinghouse on Homeless Youth and Families. Earlier this year, ACF hosted 10 regional forums and listening sessions across the country, and the forum for Region 2 was held right here in this room in April. The youngest members of our communities are also most at risk for homelessness. The Head Start and Early Head Start programs funded by the Administration for Children and Families are working hard to support children and families experiencing homelessness. The Office of Head Start is promoting outreach to families experiencing homelessness because Head Start and Early Head Start programs can provide young children with critical stability, support, and enriching experiences that promote healthy development. And that type of environment becomes even more critical if you are experiencing homelessness. In January of this year, Dr. Deborah Bergeron, who's the director of the Office of Head Start, launched the Home at Head Start campaign to enroll more children and families experiencing homelessness. And people think of Head Start maybe as a child-only program, but it's not. There are services for the parents as well. Parental involvement is very important, a critical component of Head Start. In closing, I want to encourage all of you to look at some of the resources that are available online. I've already mentioned the National Clearinghouse on Homeless Youth and Families, the ACF Office of Planning, Research, and Evaluation, OPRE for short. They've supported quite a bit of research, which is available online at www.acf.hhs.gov. For those who are operating family shelters, family supportive housing, and programs serving families experiencing homelessness, there's a series of resource guides and tools designed to self-assess what provisions you're making for the early childhood population. And that material is available on handout in the back. I killed several trees this morning, so please do not let them have died in vain. So please take the materials. I mentioned that for those who work with young children, there's an interactive learning series available in both English and Spanish, and it's been developed originally for professionals in Head Start, Early Head Start, and childcare, including early childhood and school-age childcare providers, as well as other key stakeholders. But it's available to everybody, and that's also available at www.acf.hhs.gov, and it's available through the Head Start Early Childhood Learning and Knowledge Center, ECLIC for short. And there's more information about the learning series, the self-assessment tools, and ACF on the back resource table. I want to thank Care for the Homeless for today's program and for the opportunity to speak to you all and tell you a little bit about the Administration for Children and Families. So now let's have a productive and a thought-provoking morning. Thank you.
Thank you. Thank you, Barbara. ACF and the work that you do gives us the opportunity to provide essential services for our neighbors that are most in need. Thanks to all of you for joining us for what is sure to be an interesting discussion. Before moving forward, I wanted to just call one thing to your attention. So after the panel, you have the opportunity to ask questions during the Q&A portion. And for those of you that are on Twitter, you also have the opportunity to ask questions via Twitter using the hashtag CFH Policy Seminar and hashtag End Homelessness. These can be submitted any time during the discussion today, and we'll be sure to include them during the Q&A portion of the program. And with that, I'd like to turn it over to the Executive Director of Care for the Homeless and our moderator for today's panel, Mr. George Nasha.
Good morning, everyone. Thank you for joining us. This morning we're going to be discussing trauma and homelessness, and we have a room with many, many practitioners in it. And so you know from your own experience working with the folks that we serve that it is unusual to find a person experiencing homelessness who does not have some co-occurring trauma, either immediately preceding their entrance into the condition of homelessness or sometime in the past. But the causal arrow goes both ways. The experience of becoming homeless, the experience of being homeless, also can be a traumatizing experience. We have to also, and in the last 10 years we have, to a much larger degree, take some responsibility for the uncomfortable fact that even the way that we deliver services can, in certain respects, be traumatizing. And I'm hoping that this fact comes out from our panel members this morning, and that we have the opportunity to have a discussion about the places where we may be prompting trauma or prompting people to remember trauma from long ago in the way that we deliver services. This sensitivity to the way we provide services has kind of fallen under this general rubric called trauma-informed care. And the literature on trauma-informed care is just growing now, but it's been very helpful because it calls attention to two important facts. One is that we need to be delivering programs in ways in which people are in fact safe and, equally importantly, feel safe. Those are two different things, but very important. The second thing that we need to pay close attention to is the opportunity to help people heal from trauma by giving them control back. Experiencing trauma to a large extent is the elimination of control from a person. And so if you think about someone coming in to receive services from a fairly institutional program, the types that we run, you know, you're an adult and you need to have a curfew all of a sudden. That's an elimination of some level of control. You're a family and someone else, in addition to yourself, has a key to your unit. Imagine being someone who's experienced intimate partner violence and someone else on the staff who you don't know has a key to your unit. So these are complicated questions. I'm not suggesting there are easy answers, but I think one of the things we want to accomplish this morning is ensuring that we have a robust discussion about ways that we can practice in a different way. This is not a theoretical discussion this morning. It's about how we can practice in a way that's more sensitive to the trauma that people we serve have experienced. We're going to do our best this morning to focus on three areas. I'm sure we'll depart from this to some extent, but we've got a first-rate panel of real experts in this field who have an enormous amount of experience. And we're going to focus on these three areas. One is family homelessness and how trauma impacts families coming into the shelter system and what we can do, more importantly, in our programming to help ameliorate that trauma. The second is people who are living on the street, one of the most traumatic types of and visible types of homelessness that we have in our city. And particularly the way that mental health and substance use disorders interact with the people living on the street, and what steps we can take to help bring people indoors. And thirdly, we've got an enormous privilege this morning to have a person with significant lived experience of homelessness on our panel. And I think that the learning that we will do from this person's comments this morning will be significant. I personally have learned an enormous amount from Michael in my tenure at Care for the Homeless, and I'm very excited that he's agreed to share his experiences with us and make certain he's keeping the service providers honest, and that's really one of the greatest values that Michael brings to our organization. So I would like at this point to invite the panelists up. You have full biographies in your brochures. We'll ask them to introduce themselves briefly, and then we'll dive right into the questions, so thank you. If I could just start to my left with Dr. Littleton, if everyone could just introduce themselves briefly. Your full bios are in the packages, so but just let folks know who you are, please.
Hi, my name is Andrea Littleton. I'm a family physician. I am medical director of BronxWorks, and I'm also a medical provider at Care for the Homeless, and I am on faculty at Montefiore and teach residents and medical students.
I'm Mike Boston, and I'm currently homeless, and I've been homeless off and on throughout my life for about 25 years.
Hi, I'm Scott Auwarter. I'm with BronxWorks. I oversee all of our homelessness programs, which include street outreach, family shelter, safe haven, regular shelter, and supportive housing programs.
Hello, I am Frances Pierre. I am the Commissioner for the Department of Social Services in Suffolk County.
Welcome. I'm Regina Olasin. I'm Chief Medical Officer at Care for the Homeless.
So let's dive right into family homelessness. I'm going to pose the first question to Regina. Regina, from the medical perspective, what do you see as the impact of trauma on children and families experiencing homelessness, both the experience of becoming homeless and also what trauma in the past brings and how it impacts people's health and well-being and their behavior going forward?
It's a really leading question. As we heard in the introduction, most appropriately, unfortunately and painfully predictably, adverse childhood experiences lead to a trajectory of what has become a cycle of poor health, mental health, and poverty. And this has all been very well substantiated in studies done on populations that were actually not indigent or homeless. Out in California in 1996-98, the Adverse Childhood Experience Study, Kaiser Permanente, and percentages of exposure to physical, emotional, or environmental adversity, be it family, domestic violence, food insecurity, housing insecurity, financial insecurity, observation of domestic violence, neglect. The children have poor school attendance, are socially ostracized, have early sexual experiences, poor school attendance, dropout, early pregnancy, increased use of substance abuse disorders, leading into adult conditions of behavioral health conditions, many of which could be prevented with resilience, and then medical conditions of hypertension, diabetes, asthma, substance use disorder, and early death. The chronically homeless individuals who experience homelessness on a chronic basis die 10 to 15 years sooner than stably domiciled peers, which is a huge tragedy. So basically the entire healthcare and social service system is impacted by adversity in the first 3 to 5 years of life, much of which could be positively impacted by sensitive institutions and trying to have a constructive, resilient impact on families and children. That's more easily said than ever has been done.
So as someone who supervises doctors, nurse practitioners, and nurses interacting with people experiencing homelessness on a daily basis, what tools do you provide to the people who work with you to be more expert, more skillful, and more sensitive in dealing with folks who have experienced trauma?
The biggest challenge, I think, for professionals is to realize that individuals experiencing homelessness are the professionals in their life, and this mandate of directives and prescriptive approaches that everyone is taught in their professional preparation in many respects is what needs to be communicated differently. The concept of trauma-informed care is an excellent concept. Meeting people where they are in their life is a lot more difficult. As a physician, not uncommonly, we have long lists of everything that needs to be done for everybody at every age to make them live longer, not necessarily happier, but ostensibly healthier lives. And that's kind of brutalizing. And very often, what someone would want to have done and what could be done constructively may be only a very small piece of what needs to be done from an overall health perspective. So I think the tools for effectively operating in a trauma-informed care organization, or in a medical context, overcoming the first barrier of seeing someone as a patient and seeing everyone as a person, and being able to connect and on that level. And again, there's sort of a counterintuitive approach, I'd like to treat everyone the way I'd like to be treated. Not really. If I like espresso every morning and you drink tea and I give you espresso every morning, I think I'm doing you a favor, but maybe not. And the idea of meeting people and asking how and what you can do for them is a difficult tool, but probably a very straightforward and the first tool in being able to provide services most effectively.
Fran, as someone who's overseen family shelter for many years, what challenges do people bring entering a shelter who have been through a traumatic experience? And I would argue, without any disrespect to our friends at DHS, that the experience of coming through PATH, as humane as DHS tries to make it, is itself a traumatic experience. And what can we do as service providers to help address that and make the transition into shelter easier and less traumatizing?
George, I think, like you said, no disrespect to the Department of Homeless Services, but normally when a family comes to shelter, they're really looking at alternative places for the family to come. So coming to shelter is really the last resort. So when a family comes to shelter and they enter into the shelter system, just the way operationally we function, the first person that greets you is the security, and that's not the most welcoming way of having a family come in with children. I think one of the things that George and I, and I'm sure other family providers have fought against, is having metal detectors, right? So that when a child is coming to shelter, a place that they're supposed to feel safe and secure, I think if you're walking in the door and you see a metal detector, that doesn't make you feel very safe and secure, contrary to popular belief. So I think, again, operationally, what does our structure look like? Right? How do we welcome the folks into the shelter, family with children, that doesn't re-traumatize them? I think is really, really essential, and how we look at that. And some of the things that we've tried to do, even when I was at HELP, is when a family comes in, you're looking right away to conduct an intake. How about, you've been at PATH all day, would you like something to eat? Is the child hungry? Perhaps they want something, so just thinking of the simple things.
Is there a play area near the intake?
Exactly. Where can we have the intake? Is it children friendly? Is it child friendly? And I think those are the things that we really don't think about when we talk about traumatizing, re-traumatizing an individual, mostly a child.
So, we're all concerned about critical incidents and reporting critical incidents. In your experience, do a lot of the critical incidents that occur emerge because people are dealing with trauma they've experienced in the past? Is there a way of approaching people who are behaviorally challenging that will help to make everyone in the shelter safe, including the staff, but also move the behavior in a better direction?
Well, I think that at the end of the day, you want to ask the person, why now? Why did the family come to shelter now? There's no friends, there's no family, there's no one else for you to come to. So when we talk about incidents, you're really talking about behaviors that have been exhibited to the extreme that this family member, for whatever reason, is not welcomed anywhere else. So our approach to dealing with families and children has to be engaging. There was a time where we were really passionate at what we do, that we really cared about serving folks, and it wasn't just a job. How do we make it more than a job? What do you need today? How do we get you out? One of the things that shelter was created for, especially with families with children, was don't make the family comfortable.
Yep.
What?
Yep.
Move them out as quickly as possible, so don't make them comfortable. Well, curfew, like we discussed, is already uncomfortable. So we can't hang a picture on the wall. We can't normalize it to the best of our ability, and we think that that's going to lessen an individual moving out quicker. It doesn't make sense.
So we've spent, you and I together have spent many years trying to broaden the training around trauma and the way of crisis de-escalation that we want people to use, well beyond the case managers and housing specialists, including food service workers, security guards, maintenance workers. Talk a little bit about how we can sensitize, for example, a maintenance worker who may be needing to enter a unit to make a repair, but in that unit is a family that experienced domestic violence. And how do you train someone to be sensitive to that and to do that in a way that's not going to re-traumatize the woman and the children living there?
Yeah. I think we talked a lot about trauma-informed care and how do we decrease anxiety and decrease fear. So again, really letting people know that this is their temporary home. So if you're a maintenance worker, I think I'd like someone to knock on my door before entering in, and not knock and walk in right away, but knock and wait for a response. And I think sometimes we just take certain things for granted. You know, calling a person by their name and not by their unit number. You know, oh, that's, you know, family 401. 401, what are we, in jail? You know, why are we approaching our families and our children that way? I think that helps to bring a sense of normalization and, again, lessens the trauma.
So simply living on the street in New York City is a traumatic experience in and of itself, and very many times people who are living on the street have gotten there through the experience of a series of traumas. Mental illness, substance use disorder, perhaps being released from prison after a long time without an aftercare plan and a place to go. Scott, talk a little bit about, you are one of the most experienced street outreach providers in New York City. What do you see as the intersection between trauma and the folks that you've worked with over the years on the streets of the Bronx?
I think trauma is a significant factor in almost everybody's descent into homelessness. You know, trauma is associated with certain types of severe mental illness, including serious depression and bipolar. Trauma is also clearly associated with serious addiction. And what we see with our street homeless population are a lot of people that have either serious mental illness, serious addiction, or both. And interesting, you know, in preparing for this, we also run these programs called Safe Haven programs. And George knows these because when he was deputy commissioner at DHS, he was one of the guiding forces behind this whole movement. So in preparing for this, I was speaking to Andrea Kepler and a couple of other people at BronxWorks, and about, you know, and they hear these stories over and over again from folks that we've coached off the street, which sometimes takes years to come in and take a bed in a safe haven program. And one of the stories we hear over and over again is not only was the person abused and neglected as a young child, but they ended up in foster care or in the criminal justice system afterwards. So trauma is alive and well. Sometimes it starts very early on in the family. Sometimes it gets really made significantly worse. You know, if the child ends up in foster care or group home placement, we hear from a lot of our clients that they were in group homes at one point or another. And then it gets made even worse, you know, if they end up in the criminal justice system.
So for many years, the treatment options we had to offer people are, you know, congratulations, we'll invite you to join a residential abstinence program, or we'll sign you up for a methadone maintenance program. We now have some new technology and some new medication, buprenorphine in particular, that allows us to treat folks in a different way, hopefully a more respectful, and as you said, bringing services to where people are at rather than expecting them to jump through our hoops. How has buprenorphine changed your practice?
Yeah. So buprenorphine is a medication used to treat opioid use disorder, and traditionally it's been around for many years, but a lot of times it's not the option for people who have opioid use disorder. Many of our patients had been prescribed methadone, which is also a medication used for opiate use disorder, but it has a lot of other consequences with it. You usually have to go to a program every day to get the medication. A lot of medications call methadone liquid chains because you really can't have a life when you have on a methadone program, right? It's very stigmatizing because you have to go to a program. The only reason you'll go to that building is if you have a substance use problem. So people know that, and a lot of times they're preyed upon by people who are selling drugs and other people who might not be there to support them. So for many reasons, methadone is not the option of choice, but for the longest time, it's been really the only option given to certain populations of patients. We know this because there's been research shown that the amount of buprenorphine prescribers, which is a much better alternative to methadone in the sense that it's a prescription. People can go about their day and live their lives and get their prescription monthly. And it's not, in terms of a medication, it doesn't have as many physical side effects. So a lot of people feel like they can be their normal selves and think normally, whereas methadone is much more sedating, and a lot of times people can't do that. But traditionally, buprenorphine hasn't been prescribed or being offered as a prescription for certain populations. It's highly prescribed in Manhattan and in Staten Island, but in the Bronx, although there's a lot of providers who have the ability to do it, you have to take a special training and have a waiver to do it. Despite there being a lot of providers who have that waiver, there's not a lot of providers who actually prescribe it. So it's not offered to a lot of patients in the Bronx, and I have been doing buprenorphine for our population for several years and have found it to be extremely effective. It really helps to at least stabilize one aspect of their lives so that they can start to work on some of the other things in terms of getting the paperwork that they need to get housing. We've started to do an initiative to really prescribe to people who normally wouldn't have been prescribed to, and using it kind of as an engagement to get people who are still living on the street, who are struggling with their substance use, so that hopefully they will come in doors and start working on other aspects of their lives. So I found it to be extremely life-changing for a lot of people.
And if I may say, has been the doorway to people coming in and receiving medical services, getting diagnosed with hepatitis C, and then Dr. Littleton curing them of their hepatitis C, because we can now cure hep C. So Dr. Littleton is one of the largest panels of people experiencing homelessness on buprenorphine. She's done extraordinary work in the Bronx.
Thank you.
I'm going to ask a slightly provocative question. I thought we were doing housing first. I thought we were going to move people into housing, wrap services around them, and then cure them of everything else that was going on in their lives from the perch of housing. What's going on in reality?
That's a good point. I guess we're still a believer in the housing first model. The fact is that if you're living in shelter, especially if you're living on the street, there's nothing romantic about living on the street. And I see these accounts where people say, oh, people like living on the street, which I think is, foolishness. People end up out on the street because they see no other choice. So I still am somewhat of a believer in the housing first model. I mean, which is basically, it's really hard for people to work on their problems, in their addictions, when they're on the street or they're in shelter. And it's much easier for them to be able to make progress when they have their own apartment and their own roof over their head. On a practical basis, though, you have to have some degree of stability to be able to do anything. And getting people who have a close to out of control opiate abuse disorder started with buprenorphine starts them on the path. They usually end up in a safe haven programs or some sort of temporary facility before they end up in an apartment. But again, I think some of the principles of housing first are still very important and something that, again, we believe in. But the fact is, on a practical basis, there's usually several steps before they can, before they're ready to be able to move in someplace.
Mike,
what do you think about that? Do people live on the street because they choose to?
Go ahead, Mike. Go ahead, Mike.
First, good morning, everybody. Thank you for coming out. I keep hearing about opiates and addiction and this and that and the other. I know people who are living in their Chevy Caravan or their pickup truck near Grant's tomb, not because they choose to, but because they have to, because they might be undocumented. I know people that have went through Hurricane Katrina, and because they couldn't get their lives back together. Once they left New Orleans, they're out on the streets. I think we tend to forget New York is one of the most expensive real estate, one of the most expensive real estate entities in the United States. The individual just spent $328 million on a penthouse and the air rights to that penthouse. I can't compete with that. I don't care if I hit a Powerball every day of the week, I wouldn't be able to compete with that. And people are being priced out, people are being forgotten. You know, it's like me being undomiciled. I don't like the word homeless, and a friend of mine from Britain actually said, don't say homeless, Michael, say undomiciled. It's much more beautiful. It's like, when I hear homeless, I think of crackheads and vagabonds and alcoholics. And it's ironic how I can be put in a shelter, and they'll spend $1,500 to $4,500 a month for me to be in that shelter. But why are you warehousing abandoned apartment buildings? Walk from 72nd Street to 96th Street on Broadway and look at how it's a ghost town. In an affluent area. But it's like, you know what, the haves and the have-nots, I hate to say this, and I'm not going to sugarcoat it. If it wasn't profitability and people being homeless, guess what, it wouldn't be a homeless problem. So if everybody in this room was homeless right now, let me put it better like this. If homelessness was a war crime and this was World War II, a lot of people would be going to the Hague.
So Mike, you're very knowledgeable about the homeless service system. You and I have had many conversations about it. What doesn't work for you? What is it that is not available that you think would make a difference?
Well, my therapist is talking to me about, oh, I went to yoga and I just came from Cancun, Mexico. Oh, guess what? I'm sorry, I was sleeping on the 1 train. How's that helping me? Don't talk to me like we're friends. If you don't really love your job, leave this field. Leave this field. Please leave this field. In the 8 years that I've been homeless this time, and it wasn't that I wasn't working, I was that piece of furniture in my family's house and that walking ATM machine where it got to the point, I'm sorry, I can't afford to pay all this no more. You need to leave. I know 4 people that have died on these streets and 1 person that committed suicide in the 8 years that I've been homeless this time. I think it's disingenuous to say that you care, smile on my face, pat me on the back, and say, oh, this is the best I can help you. Go to Ward's Island. Leave your credentials home, go stay at Ward's Island for a month. I won't complain. Leave your credentials home, don't tell anybody who you are, and go stay at the same places you recommend other people to go. If you can't do that, please don't talk to me. Don't waste my time. Because you really don't care. If there wasn't profitability and people being warehoused like cattle, people wouldn't be doing this job.
So one thing we hear frequently is that the service system requires the person seeking services or being offered services to tell their story multiple times, to fill out multiple forms. We put all this bureaucracy in place. Regina, Fran, is this something that you hear from patients, and what are we doing to try to make this a more streamlined process so that, because telling your story is itself an exposure, it's a loss of control, and we make people do it multiple times in the course of a year of receiving services. What has been your experience of this?
That's a hard question, George, because at the end of the day, one of the things that we have not solved is the ability to have staff, retain staff. So we're talking about telling your story over and over again, with clinicians, but sometimes they're telling the story over and over again to case managers because they've turned over so quickly. So I'm not sure if we've actually mastered that to the best of our ability. But doctor, you may know better than me.
And I don't. And unfortunately, it's also re-traumatizing. And I think worse than that, there's unintended consequences occur with a lot of well-meaning initiatives and the awareness of social determinants of health. All of a sudden, it's become something that we want to be able to document the social complexity of individuals for whom we are providing care. And I've said or thought that, I'm a member of a noble profession, and in the first 15 minutes of meeting someone, I'm asking you to bare your soul and take off your clothes. And I don't know that that's really a constructive way to develop a relationship. I do know that it's not a constructive way to develop a relationship. And then in terms of transparency, interesting. So, there are more and more movements towards interoperability of systems, and that's a good thing. That also can have impacts on autonomy. Do you want to have one conversation with one person and have that follow you for 25 years? I think that's one of the elements of the electronic health record and portability and transparency that is now being scrutinized, with good reason. Similarly, population health is very, very good to let organizations know what they are doing. It also can have an impact on autonomy, because it becomes more of this, mantra. I think that it probably, we need to look at this more like banking. It's very interesting that our health information and our financial information are treated very separately. We have access to our credit score. I think that our financial information is perhaps guarded differently and more securely and more with our individual choices than our HIPAA-protected information may be in being shared in aggregate and across different domains. And yes, it's important to be able to not re-traumatize an individual. It's also important to be able to assure some degree of privacy.
Mike, this experience of telling your story multiple times and having multiple case managers that interact with you, is this familiar to you, and what has been your experience?
It's so, I was a 9/11 first responder, and it's like every year they say celebrate the anniversary. It's not an anniversary, it's a memorial. And it's like every time somebody says, oh, well, what was it like? I'm like, what do you mean? What's it like being homeless? It's like, okay, have you ever been homeless? No. So me explaining to you, you really wouldn't understand. You will have your own theory of what I'm saying. And it just gets to a point after a while, it's just like, it's almost burnout for myself, telling my own story, because it's like, okay, how many times have I told the story? Why isn't there just one main database that they have all this information on? Because I've seen the turnover rate for my case management team. In the 5 years I've been dealing with my team, I've had 25 different case managers, if not more. Because they're all moving on to bigger and better things. Now, where my therapist is stuck, and I really got tired of her because she said, Mike, we're not talking about me, we're talking about you today. I'm like, do you see a therapist? She's like, no, I don't have to. I'm like, okay, I don't need you on my team because you must be cuckoo for Cocoa Puffs. That makes me nervous when you're dealing with, and another thing, 300 people on one person's caseload. I don't understand. I really don't. After a while, it just wears on you. It's like a bad videotape. Especially if it's something really traumatic that they continuously ask you about, and they don't have that information available. It's like, and then, why am I telling one person, then you're here like 2 or 3 months and you're gone? How do I know what you're gonna do with my information? I'm hearing today, be concerned about your personal information, don't let people have too much of your information. Well, this person's only here 3 months, what was the point of me telling them my information? And then you're gone, I don't know who you are. So, it just weird.
So to Regina and Andrea, we've, trauma-informed care, I would argue, is an approach. It is not yet an evidence-based practice. It's sort of a general gestalt about a way that we interact with people and work with folks. Are there evidence-based practices that people in this room can deploy for someone who has experienced trauma to help them make peace with that and move forward? Are there things that we should be doing as practitioners to help people address their trauma?
Yes, there are, and at different times. I mean, there are evidence-based parenting practices that have been very effective, both in increasing childhood resilience and decreasing parental depression. There are many interventions with children really targeting trying to have normalcy. Exposure to sports, engagement with Girl Scouts. It's a good thing, and people have heard about, and it breaks my heart, but it's heart-rending as well, the homeless Girl Scout troop. That's wonderful that exists. I think that, why does it have to be a label? It's a Girl Scout troop, period, and that's more of what is needed, more normalcy, normalizing socialization in a social service structure. And perhaps it should be a culture of engagement. What has been demonstrated is that people who when you want to know someone's name, it's engaging. And I think that's the big, healthy people are healthy because they have social and familial and friendship supports. And that's a lot of what's lacking.
And I think also just kind of being sensitive to where they're at. Some people don't want to talk about their trauma, and with kind of our trauma-informed care, I feel like we do have kind of this checklist of adverse experiences that we're trying to get from people, but sometimes people are not ready to talk about them, and it can be triggering of themselves to talk about them. And so being sensitive just to where people are at when they're comfortable, and I find which is unfortunately part of the problem, like Greco was saying, kind of the turnover of people is part of the problem, right? Because I feel like when we don't have that time with people, we can't gain that trust, and we will never help them progress in their lives. And so somehow being able to keep people, and continue the work that they do, so that they can build a relationship with the person they're working with, so that they can get to a point where maybe they can start to talk about some of that.
So that's an important point, I think, this need to establish longitudinal relationships with people so that they feel comfortable over time. None of us feels comfortable with another person in a single session, but given the transience of many of the folks we serve, that becomes difficult. And Regina and I spend hours and hours and hours every week attempting to make our system work in a more longitudinal way rather than this sort of as-needed basis. How important are those long-term relationships, and is our service system set up to promote that, or is the service system detracting from that?
I think you pose a very good question. Just on the point of asking people, going through using these different screening tools to assess trauma. I read through a couple of tools over the last couple of days in preparation for this. And there's questions on there like, for example, have you been raped? Or were you sexually abused as a child? It's not only, you have to think long and hard before you're going to ask somebody a question like that. And you better be ready and prepared for an answer, a positive answer, and you better know how to take time and answer it. Otherwise, don't ask it. Or you just re-traumatize the person and you make things worse. So I think that that's something that's, really essential and important to look into. I also think there's things we can do as institutions to try to negate, re-traumatizing people. Our security staff probably have more interactions with our clients and our shelter programs than any other staff. At BronxWorks, we train everybody. We train everybody in CPI, and I can't remember what CPI stands for, but it's a 2-day, all-day training on how to de-escalate tense situations and try to get people to resolve problems, before they turn into something, far worse. Making sure that staff, including security and maintenance staff, don't inadvertently trigger people's trauma is another important thing that we can do. And being a trauma-informed organization isn't a one-time training. It's a culture. It takes coaching. It takes repeating. It takes the core value of trying to treat each person that comes into your building as an individual, with respect and dignity. It means that you're willing to collaborate with people around their treatment plans and so on. It's not an easy thing to do, and it's not something that people are going to learn to do in a single afternoon.
I think the other thing that Michael said is that we have to show that we care. And having a team approach can really work. When a team is sitting together to discuss how the day went, it's almost like, you're in a hospital and you do a briefing for the next shift so that people are not asking the same questions over and over again. Like Scott said, your maintenance team, your security team, they're part of that team. And there's information that they may have sometime about an individual or a family that they can share that can help you help the family to move forward. So I think really being mindful of the caseloads that people have, having conversations about that, and caring, okay, what's the next plan of action does that individual or the family want for themselves to move forward?
I think safety is a big aspect of it, and I think that's something that our shelter system totally doesn't address. I mean, I work at the living room, which is a drop-in shelter, which means people sleep literally on plastic chairs. And I'm always encouraging people, and they develop a lot of medical problems just from that, swelling in the legs, worsening back pain, clots in their legs from sitting all the time. And I kind of try to encourage people to go to the assessment shelter. I'm like, go to Bellevue, go to Franklin, and you can actually go get a bed. They don't want to go because they don't feel safe there. And I think that's one of the biggest problems in our shelter system is if you really want people to utilize the system, because of all the trauma they have to feel safe. And if we can't make people feel safe, they're never going to kind of engage in and do the things that they need to do. And that comes, from the security staff and how they're treated by security and to everyone that comes across them. So I think that's a really big issue.
Mike, do we do a good job making our programs feel safe?
You mean this program here? I mean, I feel safe in this program, and it's ironic that you brought up Bellevue. I just had the experience, unfortunately. August 21st, I was assaulted, and I became very close to losing my life. I have sleep apnea, and I scrapped metal and I scrapped laptops in the Wall Street area. I found a kitten, a K-I-T-T-E-N in the garbage. Fell asleep. What made it unique, it had a dog collar, a leash, and a tag. Well, 2 people assaulted me, pepper sprayed me, and slashed me, split my head open. I don't even know what up. Opened my eyes and all I saw was blood. Went to a hospital. That was even worse. Had the displeasure of going to Bellevue Men's Shelter, and they told me they were more concerned with me getting my social services application process as opposed to me getting my medical attention. And they told me I had 72 hours to do that. I'm like, yo, wait, I just had a massive head trauma. You're more concerned with getting your little $215 a month or whatever, as opposed to me. And it's, you know, there's a TV commercial that comes on 2, 3 in the morning. You see this poor dog or cat? You can help save this animal. I'm like, okay, so wait a minute, what about human beings? You know, I'm a human just being, okay? I know people that compared homelessness to being a combat veteran. Because basically you're in survival mode. If you've never been homeless before, forget staying out there one night. Oh, I'm thankful you came out there one night just to spend the night out with us. Do it for a month. Do it for 2, 3, 4, 5, 6 months, 6 years. Imagine being bounced around and you have no control of where you're going. Going to a shelter, I don't know who I'm sleeping in that dormitory unit. I could be sleeping next to a rapist, a murderer. I don't know who I'm dealing with. And unfortunately, the support teams that we have there, they aren't the greatest because they go home tonight. Well, while you're going home tonight, that could be, Lord knows what could be happening in that shelter. You know, the security teams, I hate to say it, they just recently got their living wage of $15 an hour. So you get what you pay for. All right? And at the end of the day, they're not worried about it either because they go home at night too. You know, so it's, I don't want to say, oh, woe is me. Oh gosh, the whole world is treating me bad. No, but it's imagine what it's like. And if you can't imagine what it's like, please don't talk down to a person because you never know what their mental health might be, what their mental state might be. You know, if you can't treat somebody the way you want to be treated, and like Dr. Olasin said, you can't give somebody espresso if all they like is a cup of tea. But imagine asking somebody for the first time, so what's it really like? How traumatic is it being homeless? Don't be patronizing. Don't talk down to a person. Because if you're doing that, you already setting precedents for, in my head, I don't even want to deal with you anymore. Period. And if you come from, and this is nothing against academia, I remember in the 70s and the 80s when these Ivy League college kids were pouring gasoline on homeless people and throwing a book of matches on them. Just for fun and kicks. So, not being homeless and then dealing with that trauma and thinking it back to that, I'm like, well, how valuable was my life? I haven't even covered the area dealing with law enforcement and how they talk to people and how they treat people. But then again, I mean, they have a suicide issue right now, and we won't even cover that, but
So Mike, that's what doesn't work. And you've been very articulate about that. If you had the magic wand and could wave it, what approach would you recommend? Because a lot of people in this room serve folks who are experiencing homelessness, do outreach work. What approach would you suggest to a practitioner trying to be successful getting someone to come indoors?
don't tell me what I need. Ask me, what can I do to assist you? What can I do to help you? Don't necessarily recommend I go to rehab first. Maybe people have been in rehab repeatedly over and over and over again, and it didn't work. Stop putting me in a can of sardines. Each individual is unique. Okay, that's what makes us unique. Be patient. Sometimes people might move as slow as a turtle. Some people might be intelligent and articulate. When you talk down to a person, remember they were human and still are human. They're going through a situation, they aren't that situation. For whatever reason, they might self-medicate. Maybe I've been guinea pigged on all these different medications for my mental health issues. I have to look, is the practitioners helping me actually trying to help me or help their pockets? Because there's a big thing now with big pharmaceutical. You knew about these opiates when you were giving them out. So why should I trust you if there was an opiate issue? Why should I trust you with the medication you're giving me out? And maybe just because I smoke marijuana, that works for me. Those pills weren't working for me. Maybe I had an issue with addiction to pills or what have you when I was younger. And instead of talking at a person, talk to them, please, please.
Thank you, Michael.
Thank you.
Fran and Scott, how do we, because you both have a lot of experience overseeing family shelters, how do we create a more normalizing experience for kids in family shelters, and make certain that our programs are not re-traumatizing those kids? How do we make certain that that the kids have as positive experience as possible as you can have in a destabilizing environment by definition?
I think that that's a very good question, and I think it's very difficult to do. Family shelters in New York City run according to a certain set of rules that we don't have a lot of control over. So for example, our staff are expected to do unit inspection once every 2 weeks, whether the family likes it or not, but we still have to do that inspection. We have to do an independent living plan once a week or once every 2 weeks. Like it or not, we still have to do that. I think it's really important to keep in mind that the way you address trauma is through collaboration, through treating people as individuals, empowering people, and making sure that there is a safe environment and being trustworthy, which means doing what you say you're going to do. One of the things that we've done at BronxWorks over the last year or so is we noticed that a lot of children in our facility, school-age children, don't go to school on a regular basis. So we've made a real concerted effort to try to improve school attendance. And you don't improve school attendance by beating people over the head. You improve it by talking to parents about what obstacles are out there. Is there a problem with the DOE? Is there a problem with the school? Does there need to be an IEP? Almost 30% of homeless children have an IEP, which means they have individual educational plan. I believe it's 28%. It's far higher than the greater population, and those are important because those get the child additional services. So we noticed a couple of years ago that on average, only about 45% of the children in our buildings were going to school 90% of the time or more. And last year we had some months where we increased that level, that number to up to 70% of the children were going to school on a road, 90% or better. And again, we didn't do that by threatening people, by sanctioning people. We did that by having honest-to-God conversations with parents about barriers, and saw dramatic progress.
I think you want people to feel comfortable. I think you want people to feel safe. And I think making sure that all aspects of the team are welcoming to them when they come in, and almost creating kind of a advocacy, a peer program where you have people who can kind of be that hospitality of inviting people in, letting them know kind of what happens in a shelter. A lot of people who come in are never been there before and don't understand kind of what they can do, what access to services they have, where they can do laundry, where they can get food. So having someone who's been there, maybe a peer. Unfortunately, people usually have a cycle of homelessness, and some people have been, unfortunately, homeless for a very long period of time and have been at our drop-in shelter for a very long period of time. And in some ways, they can kind of help others who are kind of new to the system. So creating programs that can help people feel more welcomed and understanding where they can get resources for help are ways that we can approach helping them. And I think also being open and inviting when they're at where they're at can help them with that process. I wanted to speak a little bit to kind of what Regina was also saying, and I think that there's a lot of financial barriers to all of these issues, both with medical care and in like the shelter system, and parents and working and getting kids to school. In the medical side, I think that unfortunately most medical systems are challenged by the productivity, and so they providers have to see people in short periods of time, and so you can't develop those types of relationships when our system kind of drives people to see people for profit, right? And I think that for families, parents are driven by finances too, right? They have to survive, and so a lot of parents can't get their kids to school, can't help their kids with homework because they're working, you know? And so I think a lot of those things sound ideal, but when you're trying to survive and make ends meet so that you can stay where you're at, those obstacles are real. And I think, you know, like Mike was saying, I mean, the biggest problem with homelessness in our city is finances, right? People can't afford to live here, and we have to kind of look at that, I think, if we're gonna really address the full solution of all these problems.
George, I also did want to mention, as far as resources in the shelter, you know, when I was at HELP, we had the opportunity to do things like lullaby, where a mom would do a lullaby and record it so she can play with her child, you know, review it with her child. We had the reading programs where folks would come in and do a reading program for the kids, and have a library there in the conference area where kids can go and have an area that's set up just for them to do reading. So there are different activities that are available that are for free, but it takes time to find them. We did Shakespeare that is normally done in the park. We had an opportunity to do it in several of the shelters where the children would not have had the opportunity to see Shakespeare, you know, and they came out. The actors and actresses came out and did it right there at the shelter. So bringing a sense of normalization that the kids can now go to school and talk about things like other kids can as well.
So we'd like to shift this to a conversation with you, and we'd like to invite questions, comments from the audience, and you can either direct a question to one of the panelists or direct the question to the panel in general and have someone volunteer to answer. So please don't be shy. This is a group that I'm sure has a lot of questions and comments, so please step forward if you do. We have some microphones that Natalie will help you with.
My name is Romero, I represent the Floating Hospital. And one question or something that was missing in the panel, reference about the families living in, okay, you talk about the families living in shelters, in Tier 2, yeah. But what about those families living in the hotels or motels? Any comments on that?
I mean, when we're talking about motels and hotels, I know now a lot of what DHS is doing is converting those to Tier 2, so they're look-alike shelters. So I'm not sure exactly.
But one point I would make is that we've spent the morning critiquing even the relatively richly serviced shelters, right? And so even that we find inadequate, so you can imagine how appalling we find it that we in New York City, with the wealth spending over $2 billion a year on homelessness, that the best we can do is put a family into a motel with no social services. I don't think anyone on this panel finds that acceptable.
And I have another question for the panel, if you can share with me. With the new value-based payment, how you guys, how you see the future for this service for these families, especially when you're so limited about the amount of families that you have to see a day
Regina's thought about this a lot, so I'll ask her to answer.
Yeah, I think that what you said is tantamount to the description of the initiative, value-based payment. Okay, there's value-based care and there's value-based payment. And I think it really needs to be clear what we're talking about. The objective of optimizing your payment in this system is assuming the larger amount of risk, so that the more you know about the probabilities for increased expenditures, the more you're going to be able to extract from the system. That doesn't necessarily mean that that is value-based care. Value-based care is what we're talking about, is really a cultural change that is going to make many of the infrastructure supports not as necessary, because the health will be transferred to people and they'll have more autonomy to be able to not become a population of high need. And that's really the objective. So I think that we have interesting interactions with managed care Medicaid programs. I don't know that they're entirely clear on how this is going to roll out either. And if anyone else has any greater insight, I'd be very receptive to understanding that.
I would say from the BronxWorks perspective, I spent the first 25 years of my career having very few interactions with hospitals. And over the past 5 to 7 years, we have interactions with hospitals constantly. So the hospitals they do feel the pressure to do something. The fact is that chronically street homeless people cost the medical establishment a lot of money. There's 2 hospitals in the Bronx, and in fact we have a couple of people who are here that have reached out to us. We have BronxWorks staff who actually work in the hospitals trying to get homeless people back to their shelters of origin or some rudimentary housing plan together for them. And it doesn't take a lot for it to make economic sense for the hospital. I know Michael Curcio and Quinn are here, and they did some study. We were able to divert like 10 people at Bronx Care, which used to be Bronx Levin Hospital, and in a very short time the hospital saw a savings of, I believe it was over $300,000. So it is interesting. There's a fundamental change, and I don't pretend to understand value-based care and how Medicaid redesign works and all of its elements, but there is a fundamental change that's taking place across the city to really pay attention to this issue. And I think that by and large it's positive.
Okay, to do this job, the first thing is the passion. If you don't like people, that's not your job. The more important thing for me is the work and the team. If you don't do it like that, you're never gonna get nothing, you see? When you're the first to approach with a client, you never know what happened, really what happened, because the client gonna let you know what they want you know. It depends how you treat the client, the first approach, they're gonna let you know day by day, week by week, what really happened in their life, and they're gonna help you do it better with them. But you have to teach the client from the first day. They are welcome here, the place, but we are a team. We have to work together, you know? And that's helped to Susan play a lot, working with the client like a team. And the second is, we're talking about the children happy, like became homeless or living on the street. But it depends what the meaning of the happiness for you. Because many of the clients, they feel more happy outside of the street because they say the rule of the shelter, that's not for them. They feel like they're in jail, you see? And I think the client wants to keep doing something because they are disordered, they don't help them. They're busy doing something that they like. Because we have a program there, we have many things to do it, but not everybody is interested to do the same thing. We have to find what they like to put the right program to them. See? I know we have a long way to walk because many people became homeless more and more every day because the problem comes from the family. We can do nothing there, of course, but now if we're working like a team, like I said 3 times, it's the best for everybody. And think that the people like you, for example, have to be on the place of the client. I said when they come to me, I'm here today, this side of the table, and you're there, but tomorrow maybe it's me will be there. Because there are many reasons, a lot of reasons to become honest. People for the hurricane, for example. People for the family, the people who lost their family. Children that living in the environment, the aggressive, the violence, the drugs. Maybe the parents, they don't know how to treat the children because now they learn from their parents. They don't listen. The parents need to listen to people, but they can't do it now because they're holding already. We have to listen to them and to let them know we are there for them. We can hear you, what happened to you, I'm here for you. Come with me, whatever happened. They're scared because in the shelter something happened, you know. When we were there at the room, for example, with another client, we have to be careful because...
George, can I say something?
Of course, I'm sorry. My question is that what we're gonna do to try to be like a team with a client, because we have to try to the client feel they are really welcome and they are our center.
Scott?
Yeah, you know what's interesting is, I think it's, when you talk about trauma-informed care, it's also really important to remember that people are resilient. You know, just in terms of who you engage and what we see out there. BronxWorks has the contract to do street outreach in the Bronx, and since the beginning of January, we've seen almost 2,000 different individuals on the street at one point or the other. That's a large number of people. Some of those were John or Jane Does, so there's some duplication there, but still it's a large number of people. We have on our caseload only about 300 people. So there's right now in the city, there's lots of debate about how best to reach, how to reduce the street homeless numbers. I think it's really important to remember that a lot of people that are on the street are really there for a relatively short period of time and get off the street through no help of ours. In fact, I think probably the majority of people who are street homeless or on the subways at any given time are going to find their way back to their families or back to a loved one without a lot of intervention on the part of an outreach provider. I know that there's some groups that are advocating that you don't have to be chronically homeless in order to get a safe haven bed, or you don't have to be chronically homeless in order to get all these specialized services. And I think that my guess is on that's the wrong approach. I think it is really important to focus services on people who are out there the longest. The other thing that I would say about that is that we recently, there was a presentation, we had a presentation from this guy who did a study in both the US and Great Britain about, he asked people what really was the breaking point. What was, you know, you were living marginally, maybe because you know, jumping from bed to bed, going back and forth to a family member or to a parent. And so he asked people what really completed your descent into homelessness so there was no way back. And remarkably, about half the respondents said it was when their mother died. And again, I mean, you know, it doesn't surprise us. And anecdotally, I think we hear some of the same things. But a lot of times, the mother is the, you know, it is the important person in everybody's life. And when you no longer have that person who can offer like the love without any condition, the unconditional love. You know, for some people, it may be true that really cuts the last strand of the safety net. In terms of working as a team, I mean, we've been blessed. Care for the Homeless is a great, part of our team. We, our caseworkers, our housing specialists, hopefully our security staff, that's a work in progress. But everybody works together to try to best meet the needs of our clients. And, you know, there's open communication. You know, I think those are all really fundamental, the fundamentals of how you try to treat people.
As someone who's here more from the point of view of a researcher, you all mentioned the many and often severe traumas that people experiencing homelessness have gone through. And Mike, you mentioned that there is a lot of good reason for people experiencing homelessness to distrust academics and researchers. I was wondering if you all have any suggestions or insights on steps that researchers could take to earn the trust and start forming meaningful relationships with people experiencing homelessness.
So Regina and I are part of a collaborative group that's looking to make a series of recommendations to a group of philanthropic organizations to invest in kind of game-changing ideas in the area of reducing homelessness in New York City. And one of the things that we're doing is to engage researchers to go out and survey folks about what has worked and what has not worked for them in a somewhat systematic way. And I think there's a few things. First of all, we selected a researcher who is now at the University of Pennsylvania, but was one of the key methodologists and analysts at the Department of Homeless Services. So this person came with a huge bench of experience dealing with homeless people and homeless services. But secondly, I think one thing that your question prompts me to think about is, we can train people, in fact you guys do all the time, train people to execute survey instruments. Why not choose a group of people with lived experience of homelessness to be the people who go out and execute the surveys? At Care for the Homeless, we twice a year go out and do comprehensive consumer surveys, and it's our consumer advisory board that Michael is a very active member of, who actually go out and do these interviews and surveys for us. And so I think there's a way to integrate people with lived experience into the process to contribute to the work that you're doing.
I think the more we study, not to be disingenuous, if you really don't love what you're doing, don't do it. To be treated like a lab rat gets old, but if you're new in the field, I would pray that you stay in this field.
As an advocate who is at the prevention end of things and sometimes needed to refer people to the DHS system, the feedback has been overwhelmingly that of staff being disrespectful as a barrier that prevents people from returning. At Bellevue, at Olasin, even though Olasin is the gateway to presumably the safer locations people might go to, getting past that gateway is apparently difficult, that there has been disrespect, loss of dignity, and people who have suddenly been in culture shock, people who are housed and suddenly are not, are already in a disadvantageous position. So rather than saying, well, go report it to the person in charge, is there any better suggestion?
So Scott, you run a lot of programs that are kind of the first step into receiving services. What do you do to train your staff to make certain that they're welcoming?
Again, a lot of times if somebody comes into one of our buildings for the first time, they're going to encounter security staff. And we try to make sure that all of our security staff go through this 2-day CPI training. We also try to reinforce with our security staff that they treat people with dignity and respect. A lot of our, the other thing, and I know a lot of, I'm not saying, on the other hand, that I think that our security staff are always appropriate with our clients. I know that it continues to be a problem. I think that it's also really important to look at complaints and have a way to process client complaints about a staff person in a way that's honest and real. And if there's a problem, try to identify it and try to address it. I just want to say, security staff in our facilities, I was by our Jerome Avenue facility, and we had 2 or 3 people who, one morning, that were having really serious problems. I mean, they have a very, very difficult job. And they get traumatized themselves. They have to break up fights. Over the last couple of years, especially since we've been experiencing this dramatic increase in overdose, over and over again our staff have had to perform CPR on clients, not all of whom lived, and administer Narcan or naloxone. I also think that it's really important, if there is a serious incident that involves security staff or casework staff or whatever, that you have a policy and procedure in place where you're immediately taking time to try to debrief, try to go through what went on, to try to use some of the same things, trauma-informed care fundamentals that you use with clients. They have a right to be heard. they have a right to have managers and supervisors who are collaborative and are listening to what their concerns are.
Please.
Good morning. My name is Giselle Burgess. I'm from the Girl Scouts of Greater New York. First of all, thank you for such an informative panel this morning, for sharing your experiences. And thank you, Dr. Regina, for acknowledging our program and the initiative we have. And thank you, Scott, for actually supporting us. We're actually at one of his sites, so thank you.
It's a pleasure having you.
Thank you so much. As someone who has formerly experienced homelessness, we do know that it's very unstable when we're in a shelter system. And one thing I wanted to ask was, how can we advocate for a stronger and enforced policy when it comes to transferring families? You know, at any given moment we're transferred, especially for the children, giving them that stability. You can be in one borough one moment, and then the next day pack up, you're in another borough, and then we're expecting the children to travel back and forth or change schools again. So how can we advocate for that?
Great point. Commissioner?
Well, I know the main goal for the Department of Homeless Services is to ensure that we keep kids in their school district. But I know because of capacity issues, and you're nodding your head, because of capacity issues that makes it really, really difficult. I actually had a student that was working with a family member trying to negotiate the whole transportation of their child getting from one area to another, and it has been challenging. So obviously, do we want more shelters? What do we need to do? I think you just got to continue to go encourage staff or clients to go to their case managers and advocate for that transfer, especially when it's for making sure that your child gets into that catchment area. You just got to continue to advocate for that.
I would say, just as a short answer, that even though it may be necessary sometimes, I would argue that there is no trauma-informed way of transferring a family. It isn't a stabilizing, traumatizing experience.
I'm Philip Malbrach. I serve on the board of directors of Care for the Homeless. I am formerly homeless or still homeless. I have a room, but no home. I have a short answer for the Girl Scouts too. Because I'm not being hired, I volunteer a lot in policy advocacy, and one of the places where I volunteer is at the Safety Net Activists, a part of the Safety Net Project at the Urban Justice Center. The Safety Net Activists are working on that very issue because we have discovered that the city abuses the administration transfers. I've had that experience also, being transferred from shelter to shelter more than once, with very little or too little warning. In which case one tends to, as I have, lose belongings. In my case, as a writer, I had a lot of books, including a rare book that I lost. So this is a serious problem in the city, and I welcome you to join the Safety Net Project to work on that issue, because it will take community organizing to correct it in the city. To respond to the panel, thanks so much. As a writer with a sociology background, I'm interested in the broader picture, and stereotyping, I think, is very important in the broad picture, because we have people from the White House speaking, giving the wrong information about homelessness. Homelessness began, as you know, 2 years ago. That's what we're hearing from the White House. So there's misinformation coming, which promotes stereotyping and which promotes trauma. So we have the personal interactions that create trauma, but we have the macro situation too, which is very unfortunate all the way down the line. It causes the problem all the way down the line. So the policymakers are exacerbating the issue. So we have to find a way to go higher, to the very top even, to correct the misinformation that is being put out there. Finally, the issue of hospitality I view as very important, because hospitality is one of those social values that's universal. I understand that Arab cultures prize hospitality, and that if you're a businessman, you don't talk any business until the hospitality aspect is taken care of. So what implications would that have in a shelter? If you want to talk about care, if you want to talk about trust, the hospitality has to be there. Thank you.
Thank you, Philip. Great point. I think we have time for one more question, Natalie.
We have one that came in through a tweet, really quick. Oh, we actually have two, Giselle, thank you for the first one. Two panelists mentioned the high rate of staff turnover in the field. Why does this occur?
Well, high turnover occurs for a couple of reasons, right? Some of the folks that are coming into shelter are coming in entry level. So when you come in, you get the experience, hands-on, and then you're ready to move on to something else. So being able to keep people long enough, you know, that have the experience and now want it elsewhere. So that creates opportunity for them from the experience that they have. So that contributes to the high turnover.
They're all getting promoted?
They're not all getting promoted. Sometimes shelters open up and they're able to afford to give individual more money, so they're gonna follow where the dollar is.
You know, it's a function of the low wages of the entry-level positions. And so for someone earning $36,000 a year, $3,000 is enough of an incentive to move. I think that's Frank's point.
I mean, some people tend to come in and think they're Superman and Supergirl, and they can change the world, but then when they see the red tape and bureaucracy that they have to deal with, you know, something just as simple as giving somebody a Metro card, that, to no end, just blows my mind. They'll blow on the appointment, they could potentially be, the client could blow on the appointment, it could be a job, school, what have you, just getting new housing, and they'll be denied that because of the red tape with the hierarchy, so.
My name is Paul Beriker, and I'm a professor of criminal justice, the most disliked of all of them. But we're in the graduate school at Monroe College up in the Bronx, Jerome Avenue. And my question has to do with the other end of the spectrum that we've been discussing. As we societally look at mass incarceration and reduce it at the beginning end by no longer making marijuana busts or other issues, we are now seeing a move in the criminal justice system, particularly corrections, to get prisoners out, and out through parole. We just had a thesis done by a master's student who works at Help USA, who is now at the end of his rope because people get released from prison early. They're still under the direction of the Department of Parole. They can't get housing because if they find a room, even which is the only thing they can afford, it takes 3 or 4 days for the PO to approve it. And so they wind up in the shelter, and it's almost a given fact that when somebody gets out of prison after a number of years, they can't associate with other felons, they can't go back to the scene of their crime, they can't return to where they know people. So they wind up homeless and in shelters with apparently endless red tape. Now, I am, of course, as I understand that, an academic, as are my colleagues here, and we hear this. This is what we get from the people who work in the field. What initiatives are being done for the reintegration of somebody who is an offender, now on parole, where the situation, you know, just to say you can't associate with another offender, somebody who has a felony conviction can be in your circle, kind of puts you, first place you wind up in is a homeless shelter filled with people who have felony convictions. So you're already in violation of your parole. So I'm just curious, it's other end than the family and children, but it's one of the things that we hear all the time.
To support your point, I would invite everyone in the room to look at the census of Rikers Island longitudinally over the last 10 years and the shelter system census over the same period of time. And what you will see is an X. You see a decrease precipitously in the population at Rikers and an increase precipitously in the population at the homeless shelter system. I am not in any way, shape, or form advocating for keeping people living with mental illness at Rikers Island. That's the worst case scenario. But we're repeating the deinstitutionalization crisis by not providing adequate aftercare services for folks, and the only option, as you were pointing out, is for many people leaving criminal justice institutions to enter the shelter system that is not particularly well positioned or resourced to help them. So I think that's a very good point. I don't think we've addressed that as a system adequately, and I think we're bearing the consequences of that.
I know at one point in time, the Fortune Society was really a great agency. I have not had that opportunity to utilize that. because there's, like I said, the changes in the hierarchy. And it's profitable. I remember when warrant squads were actually coming into the shelter system, you know, and
The Fortune Society was defunded
see,
because of issues about shelters that they ran. And two of the kids got out, and that was the end of their funding in New York City for a long time.
oh, transitional supportive housing is a hot mess. I know somebody right now who's in transitional housing because the director of this one particular house has she wants to break everybody down. He's going through hell and he's just trying to do the right thing to stay out of jail. And he's actually trying to get a decent job. His mom's going through a double hip replacement. She won't even sign up on paperwork to be able to go visit his mother during this time period. And he's been complying with all the rules and regulations. But this particular director is just, she's really Looney Tunes. To be humble. Sure.
I agree, it is a big problem that we do need to address. I will say Montefiore does have, in terms of medical care, a transitions clinic that they hold out of CHCC in the Bronx, where people who have been recently incarcerated go and can get try to connect with services. I know they do try to connect them with housing as well, but it is a big problem that I think that we're not addressing.
And just one quick record, the Fortune Society, Joanne Page's team is going strong. I'm not aware of them losing it, but it's a very healthy and fantastic, extraordinary organization. Joanne is a real visionary in our field. Karen.
Great. Hi, Karen Ford, COO at Help USA. Thank you so much to the panelists, each and every colleague and friends there that we've had the pleasure of working in this field over a period of time and have seen the evolution and the transition of our homeless system, our homeless population, looking at the face of homelessness from being single men, that quote unquote with alcohol dependence to now being children and families of color. So a couple of things I wanted to say again, thank you. One of the areas, because there was a large conversation around welcoming and engaging, one of the ways that Help USA is really trying to make that paradigm shift in the way that we look at our population is through our structure and how we build out our shelters. And looking at our assessment sites. In our assessment sites, we've looked at color, we look at environment, we look at design, we look at really taking, a concerted effort to say, how are we receiving the individuals that enter our system? Does this space feel welcoming? Is it warm? And you're right, Scott, we have the balance of trying to work with our security teams, right, and making sure that they are trained and that they have the skills necessary in order to mitigate, to find that balance between safety and environments that are warm and welcoming. One of the questions I had for the panelists was, for us, we know that it's really long overdue having these conversations about trauma and really trying to humanize the work that we do for individuals experiencing homelessness. But how do we elevate the conversation really to take a look at the role that race plays? Because we're looking at dealing and addressing issues of homelessness with communities of color. We're constantly on the front line, the battlefield, informing communities about our men, right? Black men in particular. We have to stand and defend our approaches that having a shelter in a particular community, that's a right to shelter, but when it comes to the place of having sites that have men, it's a whole nother conversation. And so I also think those aspects for us are important. We as a system would be remiss if we didn't take a look at it from that particular lens.
All right, Karen. I think that there's a lot of education that needs to be put forth. And part of the teachings that I've seen exist has been really Black men speaking out as to how uncomfortable it may be when you're in an environment where you're a Black male and all of the things that you have to do to make people feel comfortable. And I think those conversations need to be had more freely so that people realize the impact of racism as it occurs with primarily the Black men. And I have 2 sons, so again, you're always saying make sure you have your hand out of your pocket. You know, there are things that Black men have to do in order to make other people feel safe, and I think that's just a dialogue that we have not yet freely had. So, more education.
I think we need to do more town halls like this. Well, personally, it's a two-sided coin, because some people feel that entitlement because the stereotypes, so on and so forth. But what are you doing to like forward the message of like, look, I want to do something positive. I don't want to fall back into those traps that I was in before. And it's a lot deeper. It's the music, the dress, the money to be made. I mean, I could be out of, I took a website design course last year in September. 2 weeks after that course, my laptop got stolen. I would have been out of this situation. Since that time, I've had over 6, 7 laptops stolen, 5 phones. I've even questioned even if I want to do advocacy work anymore because the people that attacked me were undomiciled. And they were the same color as me. And then just the treatment in the hospital, law enforcement, and then treatment with other professionals. You claim to be a professional, don't talk down to me because my IQs are off the scale. I could probably do your job better in my sleep than you do while you're awake. But it's just, we need to open that dialogue, and that's one of the most uncomfortable dialogues, being able to talk about the issue of race and mass incarceration, and how the prison population for women is also exploding. But we won't address that because it's easy to sweep it under the table and be like, it'll take care of itself. No, it won't.
I also think there's another thing that we as a sector can do, which is that we need to make certain that the leadership of the organizations that serve people of color in the city are representative of the people that we serve. And so we each have a responsibility to mentor leaders of color to assume positions of greater responsibility. That's important because diverse teams make better decisions. It's important because a child in a family shelter should be able to look up at the leadership of that organization and see people who looks like him or her. But there's a third, and we talk about those 2 reasons a lot, there's a third reason that we need to do this, which is that there are historic inequities. There are people who are prevented by a variety of structural factors from being on the trajectory of reaching those jobs. And we, as leaders of this sector, need to take responsibility for making certain we are smoothing that path to the top.
You do a great job there.
Yes, George does. He does an excellent job in ensuring that there's diversity that exists wherever he is. Thank you, George, for that.
I'm being told one more question.
Hello, my name is Letitia Bowie. I'm from Theater of the Oppressed NYC, and I have maybe a question and answer. We were talking about the turnover of agency advocacy. I feel that people who have been in this situation should also have a program like the WEP program. They have people who do WEP. They go on and get turned over, some of them to get city jobs and help them. I think that if people are interested who have experienced being homelessness, have a program to educate them, to help advocate for the people who have experienced homelessness, I think that would make people see eye to eye and feel more comfortable, because no one knows what someone knows unless you've been in that shoes. So you can't speak for a person if you haven't had experience being homelessness. I think that person who has homelessness should be the person who advocates, because they know what they want, they've been there, and no one can discriminate against them because they're in the same shoes. Thank you.
Thank you. Please join me in thanking these extraordinary panelists. show, we have a special guest speaker who is with us this morning and who is patiently has listened to us for a couple hours, go on and on this topic, and we look forward to hearing from him. And I'm going to invite Delise Blendon come up and introduce our special guest. Thank you very much.
What an insightful discussion. We have a very special guest joining us today. When elected officials are introduced, they're always special, but not like this. In his 10 years in City Council, Stephen Levin has been the champion for people experiencing homelessness and poverty in New York City. He's not just a leader on social justice, he's the leader. Councilmember Levin began as a community organizer. He started his career taking on issues such as relocating families from hazardous apartments due to lead poisoning and organizing the community against predatory lending. After some time in the State Assembly, he became the City Council member of the 33rd District. As New York City Council General Welfare Committee Chair, he has fought for and won impressive battles, changing and saving vulnerable lives in New York. He fought for strengthening protections for tenants against harassment by landlords. He created legislation that ensures agencies have the best possible tools to meet the needs of our vulnerable New Yorkers. He's a continuous supporter of our peer outreach program, which increases access to essential medical services for homeless New Yorkers. He's a fierce advocate of supportive housing, which we know is an absolute necessity to ending homelessness. Our friend, Councilmember Levin, isn't just fighting for people in need and against homelessness, but he's winning critical victories for us. Thank you for being with us today. Please welcome our friend, Councilmember Stephen Levin.
Thank you, Delise. I'm really honored to be here today and to be with this amazing panel. And it was wonderful to hear all the insight and ideas. And what is, I think, most encouraging is that I think there's a lot of reinforcing of all of each other's ideas, because I think that we know collectively in this room where we need to go. And I want to thank Care for the Homeless for really, and George and his entire staff for bringing us all together and for focusing us around all of these issues. So just a couple of things, and I won't be long because I know that we're tight on time. But a couple of things first, in talking about what Dr. Littleton was speaking about around buprenorphine. Actually, tomorrow we'll be hearing a bill at the council around a bill that I'm sponsoring in our committee that will require MAT, medically assisted treatment, in every New York City shelter, and have access to a physician or a physician's assistant. And this is for HASA, this is for any New York City shelter. And this in large part comes from meetings that we had with Scott and with George last year, about a year and a half ago, as we were seeing a huge spike in the number of overdoses in our shelter system just throughout, and particularly in areas like the Bronx, where we were seeing just an alarming rate of overdoses and people dying from overdoses. And so we've been advocating to make sure that the city, with the Department of Health and Health and Hospitals Corporation, are doing everything that they can to get more physicians to be able to prescribe buprenorphine, that they're able to go through the extra steps that's required from a physician to do this. And it's not easy for a physician to be a prescriber of buprenorphine. It may involve them changing parts of their practice. reorienting their practice, but it is so important that we are able to break down those barriers, because, as you said, when somebody is receiving methadone, and there are plenty of people who prefer methadone to buprenorphine, but it does have an impact on your life because of the requirements associated with it, of being there every day and having to have it administered on site. Buprenorphine is much more of has a lot more freedom involved. In some sense, I think that we're kind of turning a corner nationally, hopefully, knock on wood, and in New York City when it comes to the opioid crisis. I think there's greater awareness. We have a citywide prescription open for anyone to access Narcan. So any person in the city can walk into a pharmacy and get a Narcan prescription. I think we're changing the conversation. We're seeing what's happening now in the state attorneys general in their lawsuit against, and led by our great attorney general, Letitia James, on the lawsuit against Purdue Pharma, and really chasing down how this privately held company has moved money to foreign bank accounts and protect themselves from bankruptcy. Meanwhile, with 60,000 people a year dying from an opioid overdose in the United States. So we'll be hearing that bill tomorrow, and I just want to thank George, Care for the Homeless, Scott, who was really on this, on me last year about this, and this is coming out of that, so hopefully we can see this passed in the next couple of months. Next thing I just wanted to mention was just the importance of investment. It's not the only reason why I was late this morning, but it was one reason why I was late this morning, is that the trains were running slow, and the new president of New York City Transit, Andy Byford, who's a British guy, came here, and the first thing he says is we need to fix the signals. Our signals are 100 years old, and that's why our trains run so slowly, and that's why there's all these delays and backups in New York City's subways. It's because we have an antiquated signal system, because we haven't invested in it. Now, investing in it, he came out with this number, it was like $30 billion over 10 years, but that's what it's going to cost to get all the signals up to date. And there's some analogy to the way in which we as a city are investing in combating homelessness in New York City. We haven't invested in it. We refuse to invest in it. We nickel and dime it so much that, and then we're surprised that that there are 60,000 people living without a home in New York City shelter, because we haven't done the investment in the affordable housing. We won't do the investment in making sure that the vouchers, you're able to afford an apartment anywhere in New York City with the voucher limits. We're not investing in transitional housing. We're not, like the Fortune Society, we're not investing in enough, the supportive housing is going in the right direction, but we're falling behind our where we're hoping to be, our goals already on the NY 1515 plan. And our city's budget, I'm at the city council, the city's budget is a reflection of our priorities, it's a reflection of our values. And I don't think it represents our values accurately to say that we're going to spend $2 billion on shelter, $2 billion on shelter, instead of spending less on building the affordable housing, on getting the supportive housing, on making, investing in housing specialists, investing in making vouchers competitive, investing in the Housing Our Futures campaign, which is 24,000 units of the new construction to be set aside for people exiting shelter. It's all about priorities. We have a $92 billion budget. Since I've been chair of the committee for the last 5 years, the DHS budget has doubled. The DHS budget has doubled. It's gone from about $1 billion to $2 billion. And it is we absolutely have to reorient our priorities and say, you know what, maybe like the subways, it might take a lot of money to really systematically address these issues. But if we don't do it, we're just going to be paying more money over a longer period of time and not having the impact that we want to see. So that's just my take on it. One thing around trauma-informed care that we're excited to work on at the council, we have a small initiative, and it's kind of like an incubator, and we work with some of the great organizations that are here, BronxWorks, Henry Street Settlement, Women in Need, or WIN, Project Hospitality, I'm losing track of who else, but good, really innovative programming around trauma-informed care. And we're not dictating necessarily how the funding is used for each provider, but some providers are using it for aftercare, making sure that their clients that have left their facilities are able to have access to all the resources that they had when they were there. That's Henry Street. WIN is doing trauma-informed care for all staff, including security staff. What's BronxWorks doing, Scott?
Aftercare.
Aftercare. And so this is like our way of doing some flexible budgetary ideas. And so we're hoping that will continue and grow over the next few years, and bring in more providers, and bring new modalities, and bring new ideas of how to address the trauma. Because the trauma, I mean, this is what keeps me up at night now, is, as one of the members of the audience asked about hotels. You asked about hotels. And the thought of a child, 3 years old, I have a 2.5-year-old child, a daughter, Frances, and the thought of her being confined to a hotel room that is, 250 square feet, with nowhere to run around, with no ability to have the types of services that a lot of the providers that are here are able to provide, no access to a cooked dinner, no real refrigerator, no stove, no kitchen at all, and nowhere to go. I mean, nowhere. If you have an older sibling, where are they going to do their homework when the younger sibling is asleep? There's a small hotel room, and no social workers on site, because Tier 2s have social workers under Thrive, but hotels don't. And in that situation for 450 days, and they're a 3-year-old kid. And that trauma that they then take with them, we have to do better. We have to do better. We cannot just sit by and say, okay, maybe that's the best we can do. And our Tier 2 providers that do provide that sense of home, that do care, that the staff is engaged and is in it for the right reasons, and have the right resources. You can lessen that trauma. There's ways we can lessen that trauma, but we have to get out of poorly funded, poorly programmed hotels that are disconnected from services. That's my spiel on hotels. And then lastly, right now we're in the middle of discussing closing Rikers Island, and I have one of the districts where the new facility, the new jail in Brooklyn will be, because it's where the existing Brooklyn House of Detention is. And it's a very contentious debate going on right now. But from my perspective, what I'm trying to advocate for is what we're hearing, what the best thing that we could do as a city, instead of not just tearing down Rikers and building new jails, but what could we be investing in? You hear time and time again from everyone that's working and with lived experience, housing is the number one thing. housing. And so we need to do the supportive housing that is necessary, particularly for people exiting justice-involved supportive housing, which right now, you know, the administration says we're adding another 150 beds. That's great, but like we need to add about 1,000 beds. So you know, I'm trying to make it clear that 150 new justice-involved supportive housing beds is really not the answer, and it's really setting our sights way too low. And then more transitional programs like the Fortune Society program, which and Osborne I think has a contract for some as well. But really making real investments. Again, it's all about the investments, prioritizing this. And so, you know, we need to interrupt that or disrupt that cycle between Rikers Island or our city jails and shelter system and the health and hospitals system, because there are so many people that are incarcerated right now on Rikers or in the city jails and the boroughs that are there for really, not just reasons that are just not appropriate. And there's a man who was in the Daily News a couple weeks ago that was arrested from Bloomingdale's, because Bloomingdale's and Macy's and Duane Reade and other stores have a thing where if you're caught shoplifting, you get a notice, and the notice says, if you come back here, you'll be trespassing. And then they get charged with felonies. So the Manhattan District Attorney last year charged almost 50 people with felonies for shoplifting. So there was a man who was using, I'm not sure what he was using, but he was using, and he has schizophrenia, and he shoplifted 4 pairs of socks from Bloomingdale's, and was arrested, charged with a felony, spent 8 months on Rikers Island, and then was diverted to a mental health court after that. So, you know, this was just this year. This is with all of the attention around Rikers Island. This is with criminal justice reform in the front of our minds. So, you know, there's a lot of work to do, and I just thank all of you for your commitment to doing all this. I think we just have so much, just beyond this administration and, you know, well into the future. There's, you know, I think it's great that Care for the Homeless really brings us together to recommit ourselves. So that's all I have to say this morning, but thank you so much for having me.
Thank you, Council Member. I want to say thank you to everyone for being here today. I'll start with our panelists. Thank you all for your invaluable insights. Thank you for your participation. Thank you to our moderator, George. Thanks so much. Thank you to our guest speakers, Barbara and Stephen. Thank you for joining us today. We hope that the information received today can help us continue to create positive change in our continuous efforts to end homelessness. Before you go, we'd like to have your feedback, please, on the event. It should be in your program. If you can fill this out and submit it in the yellow box on the registration table, that will help inform our decisions going forward for events like this. Thank you all for being here. Thank you for your presence, your thoughtful questions. Thank you very much. Have a great